Hello, everyone. We will give everyone just a second to join us here. We will get started shortly. Thanks for joining. We're going to get started here in just a moment. All right. Good afternoon or good morning, everyone. Thanks so much for joining us today for our August 2024 PQA Quality Essentials Webinar. I'm Amanda Ryan. I'm the Director of Education here at PQA, and I will be the host for the webinar today. Our topic is Advancing Medication Therapy Management Quality Measurement. Before we get started, I'd like to call your attention to just a few housekeeping items here. First, please do submit your questions to us. You can use the Q&A feature that you see at the bottom of the screen here on Zoom, and we can use your questions as part of our discussion today. Second, both the recording of today's webinar as well as the slide deck will be made available to PQA members. That will be in about a week from today, and you'll be able to find those on the PQA Member Resources Library section of PQA's website. And then in addition to that, we will be posting the recording of today's webinar on PQA's YouTube channel. And then finally, I'd like to ask you to please complete the survey that will populate at the end of the webinar today. It takes about a minute or so, and it really does help us to inform our future programming. And now it's my pleasure to introduce you to our speakers today. First, from PQA, we have Melissa Castora-Binkley as well as Carly Vogel, and they are going to summarize PQA's report to advance medication therapy management quality measurement, which was released earlier this week. And then also with us, we have 4 panelists who will react to the report and provide their perspectives on how to move quality forward. Our panelists are Amanda Brummel from MView Health Fairview Network. We also have Catherine E. Cooke from the University of Maryland. Also with us is Larson from United Health Group, and then Anita Pothen Skaria from Centene Corporation. Thank you to all of you for being with us today. And with that, I will pass the floor over to Melissa.
Thanks so much. Hi, everybody. Thanks for joining us. Before we dive into our webinar today, we want to thank and acknowledge our sponsors. The first phase of this initiative that you'll hear about today was funded in part by Novo Nordisk and Outcomes. PQA General Funds, which include dues from our membership, also supported this work, so thank you again. Here's a quick overview of today's presentation. We'll start by briefly reviewing what MTM is. We'll go over our Quality Innovation and Research Initiative. Then we'll review each element of the call to action. And finally, we'll hear reactions from our panelists. I know that many of you are familiar with PQA, but if you're joining us today for the first time, I want to take a second to introduce our organization. PQA was founded in 2006 as part of a public-private partnership with CMS to assist with the Part D quality program. Today, PQA is a nonprofit, member-driven organization dedicated to improving safe, effective, and appropriate medication use. We have 4 main functions, including quality measurement, research, education, and convening. Now, moving into the focus of today's webinar, the MTM program was established by the 2003 Medicare Modernization Act that also established the Part D benefit, and services began in 2008. The CMS goals for the program are to ensure optimal therapeutic outcomes for beneficiaries through improved medication use and to reduce risk of adverse events. MTM includes high-touch interventions to engage the beneficiary and their care teams. And everything we cover today will focus on the Part D MTM program, but may have implications for other similar medication management services. MTM services are inclusive of interventions for both eligible beneficiaries and prescribers. They include an annual comprehensive medication review with written summaries in a standardized format, quarterly targeted medication reviews with follow-up interventions, and information about safe disposal of prescription medications. PQA launched the Quality Innovation and Research Initiative to advance medication therapy management quality measurement, which has been a national initiative for more than the last year to advance MTM quality measurement and improvement.
There is both a need and opportunity to improve the evidence base, practice, and data interoperability standards, and patient-centeredness to advance MTM program quality assessment. PQA has been working for many years to advance MTM quality measurement beyond CMR completion, and we have some new momentum now, including this initiative, which we are very excited about. The results of the enhanced MTM model point to how we need to continue to focus on improving MTM quality. In addition to the high quality research that is needed to address current gaps in the evidence base, standardized clinical documentation of MTM services remains necessary in order to advance a quality measurement of MTM. We have engaged in a variety of activities to approach this initiative. We first conducted an environmental scan and then we held the PQA Convenes event, followed by a public comment period and a webinar to discuss the results of those comments. And now we are here. The final report is now published, and Amanda has dropped it in the chat. And this report summarizes our efforts during the first phase of this initiative. And next, I will dive in a bit more into each of these activities that we have completed. First was the environmental scan, and this began back in June of 2023. It included peer-reviewed and gray literature, federal resources, and 2 stakeholder surveys. We focused on topics related to the enhanced MTM model, evidence supporting the correlation between MTM services and outcomes, MTM eligibility criteria and related disparities, as well as various perspectives of MTM. We also conducted 2 stakeholder surveys to characterize the measures that are being used to assess MTM quality and to characterize documentation practices, as well as the use of PQA's medication therapy problem categories framework. Our in-person Convenes event was conducted in Virginia on November 2nd of last year. It included a series of panels that focused on patient and caregiver priorities, learnings from the enhanced MTM model, as well as quality and health equity priorities. We also unveiled our draft call to action that was informed by our environmental scan. Our draft call to action had 8 elements and was available for review and input through public comments from December of last year to January of this year. We solicited input from PQA members and other MTM stakeholders, and these comments that we received were used to identify relevant stakeholders for each element and to brainstorm any changes that we should consider for the included elements, given the general comments that we received. So we received comments from 34 respondents with no overlap in organization, and we had almost 200 comments to analyze, excluding cases where a comment was not provided. The results of this public comment period are woven into our discussion of each element within the final report.
After all the efforts Carly just described, CMS published their final rule in April of this year, which contains significant changes to the MTM program, including expanding the conditions targeted to all 10 core chronic conditions, as well as including all Part D maintenance drugs in the 2 to 8 drug requirement, and changed the cost requirement to the average of 8 drugs, generic drugs, which significantly lowered the cost threshold. These changes are expected to at least double the size of the eligible population. This information contained in the final rule was incorporated into our recently published report and into the call to action. This call to action describes the steps necessary to advance MTM services. The elements of the call to action are not listed in a priority order. Rather, they represent a range of interrelated and necessary focus areas from quality improvement to quality measurement. The elements within the call to action are specific to the Medicare MTM program. Here are all the elements of the call to action. In the following slides, we'll review each one with the key takeaways and stakeholders who should be involved. These are actually very similar to our draft call to action elements, and we want to thank all of you for the input we received on refining these elements to what we have today.
The first element calls to investigate optimal MTM eligibility and targeting criteria for achieving program goals. CMS historically provided plan sponsors with flexibility within the MTM eligibility requirements, and this has led to widespread variation among plans and among who is eligible for these services. Many plans have adopted more restrictive criteria, and inequities with MTM services have been identified. The public comments that we received generally pointed to a need for changes to eligibility and targeting. After we received those comments, CMS published their April 2024 final rule that Melissa just discussed, with the objective to address eligibility gaps and reduce the variation between plans. Because of those changes, we need to continue to monitor the impact that they have on achieving program goals. PQA can play a supportive role to investigate the impact of eligibility changes, but other relevant stakeholders, including academic partners, plan sponsors, and MTM providers, are needed to provide feedback and research for CMS to continue improvement efforts for MTM within their authority. The second element calls to enhance collaboration between prescribers, MTM providers, and plan sponsors to better address patient goals of care and to implement appropriate medication changes. So we know how important the relationship is between pharmacists and prescribers. Research supports that as well. The public comments that we received expressed that collaboration will improve patient participation, better meet patient preferences, can increase acceptance of recommendations and improve patient outcomes, as well as alleviate prescriber burden. CMS encourages coordination of care through MTM services by sharing information across providers to reduce duplicate therapies and drug-drug interactions. So interoperability is essential to achieve this element. PQA can play a supportive role in bringing together stakeholders to help facilitate this collaboration and to identify and share best practices when enhancing collaboration. The third element calls to optimize patient and prescriber awareness of Part D MTM services and the benefits patients may receive. There is a need to increase patient awareness and understanding of MTM while being mindful of outreach efforts and potential differences in communication preferences for some populations. Public commenters and convenes participants highlighted various benefits to increasing prescriber awareness as well. This includes a higher likelihood of reviewing and accepting recommendations from MTM providers and helping to educate patients on MTM services. Their awareness will also enable the enhanced collaboration and the exchange of information that is needed. PQA can play a supportive role here in convening stakeholders to identify and share best practices on increasing awareness, but a collaborative effort is really needed between plan sponsors, MTM providers, prescribers, and patients to achieve this goal. These stakeholders should also continue to inform CMS on best practices for engagement. The fourth element calls to amplify the patient voice to improve the patient-centeredness of MTM programs. Part of CMS's person and family engagement strategy is to amplify the patient voice. So this can be done through engagement efforts such as experience surveys, through qualitative or quantitative research, and through the use of patient-reported outcomes measures, or PROMs. This engagement is needed for patient-centered improvements of MTM and for measure development. PQA recognizes how essential patient perspectives are, and we really strive to engage patients and caregivers in our research and measure development process. So patients and caregivers are essential to achieving this element. Other stakeholders listed here can play a key role in finding that balance of amplifying patient voices while not creating burden for patients in the process. They can also ensure that populations who experience inequities in care are included in these efforts.
The fifth element of the call to action is to strengthen requirements for the use of standardized health information technology for documentation of MTM services. Data from our current MTM program reporting requirements have limited utility for measuring the quality of clinical care of MTM services because they do not characterize the clinical aspects of MTM services provided to the beneficiary in an encounter-based manner. Additionally, clinical information software for MTM generally lacks data standardization and the ability to exchange information across systems. Use of standardized coding systems such as SNOMED CT for documenting MTM services is a critical step to supporting data standardization and interoperability, as well as key for measure development. Through the interoperability rule, CMS encouraged plan sponsors to adopt standardized HIT for documenting MTM services, specifically pointing to the use of FHIR-enabled platforms. PQA can play a supportive role to achieve this element, but many other stakeholders are key for making progress, such as CMS, ONC, NCPDP, plan sponsors, and MTM technology providers and, technology vendors and providers. The next element of the call to action is to increase consistent use of the PQA medication therapy problem categories framework through stakeholder education. This element is very much related to the previous one, but provides a more specific call to action, and the need is evident through the input we received through our efforts during this initiative, leading us to call this out as a standalone element. The focus of this element is on the need for MTM providers to use a standard approach to document the patient care process, including the identification and resolution of medication therapy problems using the medication therapy problem categories framework. Without standard definitions and documentation, meaningful clinical quality measurement is unlikely. In 2017, PQA convened a technical expert panel to address this and developed this framework with input from stakeholders and based on pharmacy literature. The framework leverages SNOMED CT codes to enable standardized clinical documentation of identification and resolution of medication therapy problems. PQA and our partners in practice who regularly utilize the framework will provide education to stakeholders and promote informed, consistent, and expanded use of the framework. Through these efforts, PQA will evaluate the need for further consensus building, which may include alignment, definitions, terminology, and coding. And for the element you've all been waiting for, this one is a call to develop new performance measures for MTM quality. You may be aware that once quality measures are developed, they are evaluated against the standard criteria of importance, scientific acceptability, feasibility, and usability. These are also considered at the outset of development as part of building a business case to move forward with development. The criteria for importance outlines the need for a strong process outcome linkage. This is illustrated often through the use of a logic model where the developer pinpoints the care processes and outcomes of interest and then supports this with the literature. The standard to evaluate the evidence takes into account the quantity of the evidence, the quality of the body of the evidence, and the consistency of the results. The Agency for Healthcare Research and Quality concluded 10 years ago that the evidence is insufficient for most outcomes due to the inconsistency and imprecision stemming from the variation in populations and interventions studied. And this remains true today. Feasibility is an issue given the lack of standardized clinical data to use for a measure. Importantly, the data needed for a measure should be available, implemented, and retrievable. We do not want to create a measure and then ask for the data. The data should first be available and we build a measure around it. PQA would love to develop a new measure for assessing MTM quality. However, for now, we can play a supportive role by promoting the conditions needed before we can develop a new measure. Many efforts are needed from the entire MTM stakeholder community.
The final element calls to prioritize research to optimize the Part D MTM program and services. Echoing Melissa's point on high-quality studies, it is necessary to enhance the designs of studies evaluating Part D MTM. This includes employing adequate controls for confounders and bias, and isolating program features and their impact on outcomes. There is also a need to continue research on inequities associated with MTM services, and this includes how to assess and improve inequities, differences in MTM availability, and effectiveness of MTM across diverse populations. Patient preferences need to be investigated regarding the process of MTM, including factors associated with accepting services and their preferences for receiving information after the services. There's also a need to assess any potential unintended consequences of MTM programs. This may include siloing of care or fragmenting relationships between patients and their healthcare provider. Further insights may also be gained from enhanced MTM model data. Having this data readily available to researchers would ensure transparency and would really support external research and further learnings. Overall, research is needed to identify best practices related to the MTM program. Relevant stakeholders listed here should continue collaborating with each other to conduct studies that meet the rigor to support the MTM process outcome linkage. PQA will continue to collaborate with researchers and other MTM stakeholders to solicit and emphasize patient preferences and to identify best practices.
In conclusion, we have many challenges in front of us, including lack of standardization, inconsistent service delivery and documentation, many data limitations, a lack of patient awareness, a need for effective integration of patient perspectives, and insufficient quantity, quality, and consistency of the evidence. This call to action, combined with the program changes that will be implemented in 2025, is an opportunity for all of us to take action to advance the quality of MTM services. Subsequent phases of this work include research, education, consensus building, and quality innovation projects. What you don't see listed here is measure development. Hopefully, we've made the case for things that need to be improved in order for us to get there. As an immediate next step, PQA will launch an MTM advisory group. An email will go out tomorrow with information on how to participate. The purpose of the group is to continue momentum and gain feedback, consensus, and action toward achieving and advancing quality and measurement of MTM services. The group is open to any interested stakeholders from our member organizations. We'll meet regularly every 6 to 8 weeks for a year and then assess if we should continue. And we will send this email out tomorrow, so make sure to look out for it. The advisory group will adopt 3 main principles of flexibility, because this is a very challenging space and we may face starts and stops and need to adjust along the way. The group will be action-oriented to truly affect change and see results. The group will operate with a limited scope and the focus on Medicare Part D MTM, although activities and outputs from the group may be more broadly applicable to other similar medication management services. The group will also focus specifically on the areas that align with PQA and our influence. We will begin by gaining consensus on the goals and the related activities to advance the quality and measurement of MTM. This group will also serve as a forum for identifying additional gaps in MTM quality. And with that, I'd like to turn it over to the panel. All right, excellent. So panel, if you'd join me, coming off of hiding and unmuting yourselves for the discussion. If we could get the slide to advance one more to see the call to action so our audience can digest all the different elements here that we'll be talking about. So I'd like to start, Catherine, let's start with you. If you had to pick just 2 of these for PQA to start on, just 2, which would those be?
So, it's interesting because I think all of these are, important and kind of resonate differently in terms of priorities with different stakeholder groups. But, I think the one that kind of just jumps at me right out off the bat is kind of the patient voice. And when we talk about patients, we're talking about beneficiaries, caregivers, kind of their family members, really to hear their perspectives. And so, when we've talked to beneficiaries in the past, it really is been enlightening to kind of hear the real world aspects of the MTM program and kind of what their perspectives are, what they value, kind of what they maybe don't value, and maybe even some suggestions on how to, deliver the service or some aspects that would be more preferable to the beneficiary. So I think that's kind of number one. For me, I guess if I had to choose a second one, it would probably be research to try to understand a little bit better about the goals that are being achieved, right? And kind of tying that back to the beneficiaries. Are they patient-centered, right? I know there was some satisfaction work done several years ago that really, the question we kind of asked to the beneficiaries, are your medication needs being met? Kind of a very simple thing. So those are the 2 if I had to pare them down.
I know it's a hard choice. Aaron, what are your thoughts?
I've been thinking the targeting criteria, the standardizing that is like a nice, maybe a little more achievable, or well, not achievable, but an easier starting place than others. And I guess as I've thought about it more, I'm thinking you could focus on the inequities you've identified and use that sort of as a unifying way to keep doing research, make incremental changes to the targeting criteria, and learn about all the all the, you know, all the points in the patient's journey where the inequities are happening, whether it's targeting criteria or kind of acceptance rate, or whether the recommendations are landing, that kind of thing. So those are my two.
Amanda?
I mean, this is tough because they're all interrelated, right? And these all connect to each other, which is wonderful in many ways, because when we start to tackle one, we'll impact another. But it also makes it hard to kind of hone in. But for me, I think it comes down to the foundation of our practice and kind of our practice model. And so you could say that there's elements of 5 that fit that, but also 6. And even for me, it's not even so much about the framework, although I hold the framework very dear. I think what the framework does is it really helps us when we think about our practice model, kind of that assessment that we're doing, making sure that we're doing that in a standardized way. And I think when we think about our practice and we think about being able to measure this and think about being able to have a measurement that assesses this type of work, we need to make sure that we're consistently providing care. And for me, you know, many years ago, I remember a conversation I was having with a provider that basically said, I want to make sure that my patient at this clinic and a patient at this clinic and a patient at that clinic are all kind of getting the same type of care. And so I think that the medication therapy problem framework helps us take a step forward along with, you know, 5 in that documentation piece, to really kind of have some standard elements of the care that we're providing that help to create that, you know, consistency and standardization. So that's where I'll throw my 2 votes.
Anita, top 2.
Top 2. I think when I look at these, I think of, in general, right, we know that MTM is valuable, but we have to make sure we're showcasing that. And to me, you know, I go back to number 1 as well, like some of my colleagues here, because that targeting and eligibility is really important. And I think when within the wonderful document that PQA has put together within this call to action, there's a call out that it's better to identify the members that really are at risk and vulnerable. And so if our targeting criteria is not doing that, we have to kind of ask ourselves why and what gets us there. So I think that one is pretty important for me. I think it's a lot of what the enhanced MTM model was intended to do. So I think that from like an overall program goal is certainly important. And then similarly, from a patient and prescriber, so when I look at number 3, that patient and prescriber awareness of the benefits, because I think we have to be acutely aware that today, both patients and prescribers get a lot of outreach in a lot of different ways. And so there's certainly different ways to deliver MTM services, whether that be in person or telephonically. But when we think of telephonic or some of those less face-to-face interactions, which is what happens a lot of the time, we have to be aware that we're not the only ones doing that. Even as a plan sponsor, it's not just one team doing that. So how do we help drive that value or showcase that value by optimizing that awareness of the services and the value they bring?
So pretty much we have to do everything here, right? I think we covered almost all of them, although no one said measurement, I don't think, which is good. So you are listening. We want to do it. We just have some work to do before we can get there. All right. So our report just came out this week. Hopefully everybody on the line today has at least clicked on the link that we have in the chat. You may not have had time to read it cover to cover. Our panel, you got a little sneak peek, so I think you've had a little bit more time with it. I'm curious, what was your reaction to the report? Did you find anything surprising? Really want to know how you reacted to it when you had some time to get through it. So Aaron, let's start with you this time.
Yeah, I when I go back to the first time I heard of this effort, I was expecting it to be a smaller set of recommendations, something a little more incremental. So I was surprised. I was surprised to see how expansive the evaluation, you know, really just a complete overhaul, I would say, and and appreciate it. I appreciate the all the curiosity in kind of following where the data takes you.
Others? Oh, Catherine, you're muted.
Oh, sorry. I was going to say
Had
just
to
probably
get that in there once, you know.
Yes,
We didn't have a
yes.
webinar without that.
Probably just echoing, kind of that. I think there's so much that, you see a report and there's so much that kind of went on behind the scenes to get to this report. So, really kudos to PQA for putting this together. And I think what the report, I think, did summarize nicely, like kind of the complexity of the issues and the interrelatedness of these issues. And it's kind of, sometimes we look at things in silos, right? We're looking at one aspect of the program and trying to address that. So I really thought this was a nice kind of comprehensive overview of the challenges and how, I think Amanda mentioned this earlier, like when you kind of affect one, you're kind of affecting another one, right? Because they are interrelated and affect each other. So I think that to me was helpful to kind of see it all, the complexity and the comprehensiveness all in one spot.
Yeah, I agree, Catherine. I think being involved with this process for a long time, I can't say that there are a lot of surprises because I feel like I've been getting to see it evolve along the way. But I think what the report does well is capture the complexity and, to be honest, not try to just have a simple solution, because I think there's a lot of things that we could have done that wouldn't have been right and wouldn't have gotten us to the right place by trying to just come up with another measure, for example, or eligibility, and there's lots of changes that are happening there, but really to understand the complexity with each of these and why that we need each component of this really to bring success. And so I think it did a really nice job of kind of calling out that complexity, also highlighting all the different stakeholders that are in this, because that's important too. I mean, it's not one body that can make this work. It is all of that interconnectedness together. So I think that was really nice in being able to call that out, and yet having some tangible places where we can start, and that we all kind of agreed upon and know that if we make some impact in these areas, that we're going to be able to move things forward.
And I'd agree with that. I think it made it digestible, so going back to kind of that complexity issue, but then also realistic. There's no sugarcoating on the challenges that we have ahead or what has been a challenge to date, which is why we're here, which is why we have such an expansive list of call to action elements. So I thought that was put together nicely. And I think just that actual verbatim feedback that PQA collected from those respondents is also important, because I think there's certainly data out there. We would argue there should be more data that's a little bit more linked to MTM, but just that perspective across the different stakeholders, to Amanda's point, and then recognizing that this really is sort of it requires a team, and this is sort of a set of plays that we're trying to set up that allow us to achieve the first phase of the goal, really, to get us kind of bring it home all together.
So I'm going to acknowledge an audience question that we got in, and the question asks us if we should focus on a performance measure from a service quality and affordability lens versus a process completion for the task. So, and whether the CMS STARS metric will change. Right now, the completion rate measure is moving to display because of the changes to the program. So that will take effect for the next couple years. In terms of a measure, hopefully you can take a look at our report and understand the challenges that we face in order to create a new measure, whether it's focused on processes or outcomes. And I do want to just take a moment to plug a manuscript that we will be publishing soon. It is currently in draft, but we did talk about the evidence and the challenges we face there in the report. Our upcoming manuscript will detail that in a lot more description and detail about the studies and why we really have a difficult time connecting and supporting the process and outcome link. And hopefully, through the research that we've called for, we can be involved in helping to strengthen the designs to get us to better evidence. But of course, that's not the only challenge. We also have the data challenges. So turning back to the panel, I'd like to ask you, and maybe Anita, we can start with you this time. The discussion today, as well as the report, focuses a lot on standardization, things like documentation, different platforms for HIT. Can you provide your insights on why standardization is such a strong emphasis?
Absolutely. I think from our experience with Enhanced MTM as an example, there was an aim to standardize data collection. There was an aim to be able to tell a story with the data. And so with the utilization of SNOMED CT coding to really understand what was happening through the provision of services, the goal was to see that standardized across the 6 plan participants. And so while that may be true, and while the participants may have done that level of work, what we saw is that there was still lots of variability, that even across multiple MTM vendors, across multiple plan sponsors, everyone didn't necessarily SNOMED map the same. And so if we think of the goal of standardizing data collection and how we document is to be able to pull insights and is to be able to really see the impact of a service. If we don't do that in a standardized way, then you really don't have apples to apples to compare, or even the same level of detail. So we need to recognize how we do that. That in and of itself is a very large undertaking because systems are different. Platforms are built differently within our industry, let alone across the healthcare continuum. So if we want to be able to use data to drive the work we do, and showcase the impact we serve, we really need to understand what that data is telling us. In order to do that, we have to standardize it. And we have to do so in a way that does not interrupt care, because sometimes we kind of get lost along the way when we do that.
Anita, when you talk, if I can jump in, you know, one of the things that I think is really great about what you're saying, and it may or may not be the case, because I don't know if some of the things that you're talking about were very technical pieces of how that data came in, but I think one of the things that I'm thinking about when you're talking goes back to the point of our practice. And if we have pharmacists assessing a patient in very different ways, we're going to get different end results. And so we can have a way to codify that, but without having a consistent model that we're actually doing in that assessment, it's going to be hard for us to have replicable practice to actually be able to measure and have outcomes with. So I think it really comes into not, and I hope that the intent, and I think that the intent behind some of the standardization here is a way to gather the information to be able to assess it, but not to have that be lost on we actually have to have a standardized way of, you know, doing that patient care process or getting that information, because otherwise we're going to be stuck in the same spot of we have a bunch of data, but we didn't have a standard way that we actually approach this care. And so it's going to be hard for us to assess that.
Amanda, that's a really good point. And I can hear you from our previous discussions referring to an example that I love. So would you help us with an example by illustrating the difference between standardizing care processes versus documentation?
Yeah, I think too, some of this comes again back to kind of practice, and I'm going to take us out of our pharmacy lens and put us into another profession of dentistry. And I'm not a dentist and I don't have any family members that are dentists, but what I've learned about dentistry is that they have a standard way that they assess our mouths every time they go inside. Our teeth have numbers, and they have a standardized way that they approach taking care, you know, of your oral hygiene. And so if Anita was taking care and she was a dentist and taking care of a patient, and I'm a dentist taking care of a patient, we would all, it doesn't matter who our patient is, we would have been trained to do that in a systematic way. And I think that that's sometimes what we're missing in pharmacy. we all want to help the patient and we want to help manage their medications, but we may not have been trained in a systematic way in doing that and how we identify kind of those medication therapy problems. And so being able to kind of have that standard way that we can do that, we then can document those outcomes and they can be meaningful. I think the catch sometimes and the fear that comes up when we use the word standardization, or even more so standardization documentation, is, I'll be honest, I don't want another form like a medication action plan that I have to fill out and have a certain font and a box that needs to be filled. And I don't know that that's the intent, and my feedback in this was sure not the intent of having something like that. But having a consistent practice model and a way that we can take care of a patient and then use that to document, and documentation standards can help to bridge that, right? So if I know I have to document these things and it helps to reinforce the model that we're using, that's great. How I document it, what font I use, and what box I have to put it in, that is not what we're talking about. It's really making sure that we're capturing the heart of the care that we're providing and the elements that then help to formulate and back that up. I do think, and I will just say, I live in the state of Minnesota, and Minnesota Medicaid did this for us many years ago with their documentation standards for our Medicaid patients that we have to care for, of what kind of needs to be in that visit. And it doesn't explicitly spell all of the detail out, but it tells you what you need to do in that assessment of a patient. And it helps then to create kind of that standard of practice via documentation versus calling out exactly, you need to do X, Y, and Z. And again, I don't think that's the intent here, but I think that's the fear that some of us have when we hear words like standard and documentation in the same thing, because we don't want another 9-page medication action plan that we have to fill out.
Yeah, I was going to say, I think kind of along those lines, I remember, being a practitioner and the change from kind of documenting the way that maybe I was used to documenting and providing, the information back to the patient. And then all of a sudden it's like, here's the standardized format. And it was quite jolting, right? A lot of effort, I think, went in that maybe, helped put that information in a consistent way, but also maybe didn't really address, didn't really help care processes per se, right? If you were kind of doing those already. And I think, I liken kind of this MTM processes kind of to what, JCPP, the Joint Commission on Pharmacy Practitioners, kind of released the PPCP, right? The pharmacist's patient care process, where you're collecting the data, assessing it, planning, implementing, and then following up, right? And I think part of the challenge with some of the ways that MTM is delivered or maybe prescribed in the program is that, it's kind of an episodic type service, right? That it's kind of like, is the CMR done or not necessarily the follow-up and aspects like that. And so some of that language in there, I think, has maybe, constricted the way that normal patient care practices, right? Because I think you're in an integrated delivery model, and I think seeing patients kind of, what I would see patients in, what I call the old days, kind of in a more primary care practice model, right? My old days, a primary care practice model to do that. But I think it's kind of trying to marry those two different processes into something that's standard across the globe.
Yeah, I think your points are very well said. And I do think that some of the unintended consequences of having a CMR and having to have that be done and kind of checking that box, and some of the funding of how this program has been funded. And, and I know a lot of that is out of the scope of our call to action, but it still intertwines and really interconnects with some of the things that we do have in the call to action, because it has, those unintended consequences have happened to maybe formulate how some programs have been developed or how the work has been driven.
So there's definitely this interplay between the care processes and the HIT that can drive or support those processes. So to go to an audience question here. The question asks if there's been considerations made to how we can integrate or update our health IT systems to meet these goals without creating too much burden. I think that might be a little bit of a difficult one, but I'd like to hear from our panel if you have any experience in trying to improve your HIT systems to better serve your needs. Stumping the panel is that's where we're at. It's hard.
I couldn't get off of mute. And I don't want to talk too much, but we use a EMR platform, and we have integrated the MTPs. We actually, that vendor uses the PQA framework as a way that we can document our medication therapy problems. And so I think, that is fundamental. So it doesn't matter if I'm seeing a Part D patient or a Medicaid patient or a commercial patient, I get to use that same platform and document that patient care process in a consistent way. So I know I'm fortunate in being able to do that. And, but that has really helped. It is a part of the work process. I think the other huge piece of that is we have been able to work with our plans and payers in our area to be able to accept a file that comes over out of our documentation system that they can then use for reporting for the Part D programs. So again, from a provider standpoint, and I can do that documentation, and the plan still gets what they need, and it's all coming out of one way. And there, that was over time, and that was a lot of work for that to get done. But now, multiple of our payers are accepting that. And so I don't need to, always go into lots of different platforms. So for me, that's how it's been incorporated, and it's been very smooth and easy to be able to have that documentation help drive our practice.
Yeah, and at United, there's I guess I think we're struggling with the inconsistency out there. We do have some systems set up like that, and some that are more burdensome, I'd say. So progress on interoperability will help, and we're pushing as hard as we can. Meanwhile.
Yeah, and I think when I see things like not making it too much of a chore, I try to hesitate, because it all depends on what's considered the chore there. I think for us internally, we've really tried to honor that virtual SOAP note, if you will, in terms of how we approach that patient. So kind of going back to, again, what's the provision of the service, and how do we really, look at the patient holistically and do that in a consistent way as we move through our tool. I think we also have been SNOMED mapped as well, in terms of, having that ability to export that data. It's not lost on us either that not everyone is set up the same, and sometimes you have to kind of aggregate, to my colleagues' points here, right, in terms of the different ways that the service can be delivered. And so I think that's where many of us rely on, some level of an export because of the different platforms or the different ways, so that we can, one, meet like a reporting requirement standpoint, but then two, just kind of understand. So I think interoperability is always that fun word we like to throw around, and that's its own sort of feat. But at least internally, just kind of having that level of understanding and knowing that we have, whether it's MTM, whether it's other clinical programs, even internally for us within, that pharmacist-led or pharmacy-led space, we've been able to do it in that way, but certainly work to do there too.
Well, we're getting down to the wire here. So I want to ask you about our MTM advisory group. This is really a stepping off point that we're taking after gathering all this information and kind of putting the needs out there to the community. So we know that there's a lot more that needs to be done than what we'll be able to tackle in this group, but I still want to know from your perspectives, within 1 year, you know, we want to assess where we're at and how much we've achieved after 1 year. What do you think success would look like for this group?
So I think, you know, when you look at the report, I think in the comments, Anita mentioned this kind of from the different responses that you received from survey, which represented multiple different stakeholders, right? And so I think if you could come out with, here's the 2 to 3 priorities that all stakeholders can get on board, can get aligned and put effort and energy so that we accomplish something. You know, to me, that would be, you know, within a year, I think it's like, okay, here's the 2 or 3 that bubbles to the top that everybody kind of coalesces around so that the field kind of moves forward. I think that's what I would hope for.
I'd agree. I think something that really informs, as you really bring all of those folks together and those experts across the diverse areas, what is a roadmap that we can actually kind of align on. So I really love how Catherine said, you know, like just target the top 2 to 3 there, or top 3 across the board. But then I think also, as that group does that, making sure, you know, we know that CMR is moving to the display measure. We have a couple years there, but maybe also balancing that too, and understanding of what's within this call to action that's achievable, and are there things that maybe don't fall into the scope here that we just need to be able to call out? So for example, right now that key service is the CMR, and our goal is to deliver that service based off of the measure we have today. I know we're not getting to measurement just yet, but you know, what are we maybe missing that we need to just parking lot, and know that that's also something to tackle? Because I think there's a pretty, maybe it's a parking garage of things when it comes to MTM and the services, right? And CMR is that service. And so if there's something else there, I would say I suspect that group will have a lot of really great dialogue, and we'll have to stay focused, but let's not lose those pearls along the way either. And maybe that kind of helps us set up some next steps there.
Yeah, there's a lot to balance here. So I think consensus on a plan forward is probably the biggest thing. If they could agree on a few things to start on, and I think that'd be great.
Yeah, and I think the only thing I would add is that, you know, with tackling what we can tackle from the call to action, and having a couple of priorities out of that, if there are elements that we need a partner like CMS to be able to consider, that we kind of have that active dialogue or list that are going to help us to be able to achieve these call to actions. What do we need from them as a stakeholder? Any recommendations, especially during this big time of change?
Well, before I hand it over to Amanda for a couple closing announcements, I want to thank you all. That was a wonderful conversation. Thank you for participating, and thank you, Carly, for presenting with me today. And we can't wait to take these next steps. Amanda, it's over to you.
All right, thank you so much, Melissa. Wonderful conversation today. I'm going to close this out here with a couple of announcements and move on to the next slide here. And I'm going to pop a couple of things in chat for your reference. So I would like to let everyone know that we hope to see you this year at our PQA Leadership Summit. It's going to be held on November 7th and 8th in Arlington, Virginia. And this year's summit is going to focus on measure modernization, as well as PQA's role in the national efforts to advance and align measures across providers and value-based programs. Registration is complimentary for the Leadership Summit for PQA member organizations, and the registration link has been provided to the key contact of each organization. Also, immediately preceding the Leadership Summit on November 7th will be PQA Convenes, Quality Medication Use in Rare Disease. Your organization's key contact has also received registration information, and PQA members will receive a registration discount for this Convenes event. If you do have any questions about either the Leadership Summit or the Convenes, you are welcome to email us. That email address is in the chat, and it is meetings@pqaalliance.org. And our next Quality Essentials webinar is going to be on Thursday, September the 19th at 1 p.m. Eastern Time. This webinar is going to focus on the implementation pilot for PQA's specialty pharmacy turnaround time pharmacy measure. You can register for that webinar right now if you like. There is a link in chat that will take you to the registration page. And then finally, please do save the date for our next stakeholder advisory meeting. That is going to be on Wednesday, October the 23rd at 1 p.m. Eastern Time. Registration information will be made available to PQA members as we get closer to that webinar date, and we do look forward to seeing you there. And with that, I would like to thank you all for joining us today for our Quality Essentials. I hope you have a great rest of your day.